Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complimentary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name is Rona Yaeger. Today we're going to discuss the use of biomarkers in the treatment of colorectal cancer. We will discuss 3 cases where the presence of a biomarker changed the treatment approach. The first case is a patient who presented at the age of 50 years with blood with bowel movements. A colonoscopy at the time showed a large, high rectal polyp, with biopsy showing tubulovillous adenoma with high-grade dysplasia. He underwent a second colonoscopy to remove the polyp completely, and pathology showed invasive adenocarcinoma arising in a tubulovillous adenoma with invasive tumor infiltrating to at least the submucosa. CT scan showed no evidence of distant spread. A low anterior resection was performed, and pathology showed residual intramucosal adenocarcinoma and 18 out of 22 lymph nodes with metastatic adenocarcinoma. The tumor was microsatellite stable with retained expression of the DNA mismatch repair proteins. He received adjuvant FOLFOX chemotherapy for 6 months. 6 months later, a CT scan showed new abdominal lymphadenopathy, measuring up to 2.5 centimeters with central necrosis, concerning for recurrence. A PET scan 2 months later showed increasing size of hypermetabolic lymphadenopathy involving the periaortic lymph nodes, and molecular testing showed BRAF V600E mutation. He received FOLFIRI for 3 months with imaging then showing increasing lymphadenopathy. What here is typical and what here is atypical in this patient's presentation? The aggressive course is typical of BRAF V600E. N2 disease is often seen with BRAF V600E colorectal cancer, and there is some data for nodal proclivity, particularly atypical lymph nodes, which wasn't the case here. The resistance to second-line chemotherapy is typical in this molecular subset. However, this case has many atypical features. First, location of the primary tumor. Most patients with BRAF V600E colorectal cancer have right-sided tumors. I see more of the left-sided tumors among younger patients, as this patient was 50 years at diagnosis, and with microsatellite stable disease. The small extent of tumor involvement of the bowel wall is also atypical. Some series have found an association of BRAF V600E mutation in colorectal cancers with T4 disease. What are the next treatment options? This patient underwent lymphadenectomy to remove all involved lymph nodes. 6 months later, a CAT scan showed increasing size of mesenteric and retrochoroidal lymphadenopathy consistent with recurrence. There is data that BRAF V600E colorectal cancer is a marker for rapid recurrence after metastasectomy. I would not give an EGFR inhibitor alone in this patient because of the BRAF V600E tumor mutation that is associated with resistance to EGFR inhibitors. When he recurred, he was then started off-label by me with a RAF, MEK, and EGFR inhibitor. Specifically, I treated him with the combination of vemurafenib and cobimetinib and cetuximab. So what is the rationale and data supporting this combination? The patient's tumor has a BRAF V600E mutation. RAF inhibitors such as vemurafenib selectively inhibit BRAF V600 mutants, which signal as constitutively active monomers and don't require upstream activation. However, in colorectal cancer, these drugs have had limited activity, likely due to release of upstream receptors that have been feedback suppressed by the high activity from BRAF V600E. And with RAF inhibitor treatment and suppression of BRAF V600E, these receptors are released from the feedback inhibition and are reactivated. This appears most clinically relevant in colorectal cancer because of the high levels of receptors in this tissue. EGFR with or without MEK inhibitors are therefore added to better suppress signaling. The NCCN guidelines currently include 3 targeted therapy combinations for BRAF V600E colorectal cancer. Vemurafenib plus irinotecan plus cetuximab is included based on a SWOG study that randomized patients to irinotecan and cetuximab, or to vemurafenib, irinotecan, and cetuximab. Prior irinotecan was allowed. There were about 50 patients in each arm. Response rate was 4% for irinotecan cetuximab versus 16% for vemurafenib, irinotecan, cetuximab. Progression-free survival improved from 2 months to 4.4 months with the addition of vemurafenib. The triplet of the RAF inhibitor dabrafenib and the MEK inhibitor trametinib and panitumumab is also a listed treatment option in the NCCN guidelines. This triplet was tested in a phase 2 study with a response rate of about 21%. Finally, the triplet of the RAF inhibitor encorafenib, the MEK inhibitor binimetinib, and cetuximab is included in the guidelines based on the safety lead-in of the phase 3 Beacon study. In the safety lead-in, 29 patients were treated with a response rate of 48% and median progression-free survival of 8 months. Encorafenib binds to BRAF longer than other RAF inhibitors, potentially leading to improved clinical activity. As you can see, targeted therapy has activity in this setting, but it is not curative, as most patients progress within a period of months. Our patient of interest was treated with vemurafenib and the MEK inhibitor cobimetinib and cetuximab. He had regression of the abdominal lymph nodes with treatment, and he responded to treatment for 16 months. At progression, we biopsied a periaortic lymph node and repeated sequencing. We identified a new KRAS A146T mutation. We also sent blood for circulating free DNA analysis that picked up this KRAS mutation and also another KRAS mutation, I84T, and an NF1 mutation. The functional effect of these additional alterations is unknown, but they lie in nodes in the pathway that could cause resistance. So what can we learn from this resistance data? Resistance here is mediated by reactivation of MAP kinase signaling. We see alterations in this pathway as a common mechanism of resistance to targeted agents, such as EGFR inhibitors, combination therapy for BRAF V600E mutated tumors, and HER2 inhibitors in colorectal cancer. Circulating free DNA can pick up the heterogeneity of resistance. Circulating free DNA analysis of patients with BRAF V600E colorectal cancer treated with targeted therapies often show multiple resistance alterations within the same patient. For example, multiple RAS mutations, as seen in this patient. Our second case is a 48-year-old man with no family history of colorectal cancer who presented with an MSI-high cecal colon cancer with extensive nodal and hepatic metastases. He was symptomatic with fatigue, constipation, abdominal pain, a weight loss of about 40 pounds, dry cough, and dyspnea on exertion. Labs were notable for elevated bilirubin to about 2, a mild increase in his alkaline phosphatase, and transaminitis. He was started on FOLFOX chemotherapy and received 4 cycles. With treatment, he had some improvement in his cough and shortness of breath, but the fatigue and abdominal pain and weight loss persisted. He continued to look ill. CT scan showed no substantial change in the abdominal and retroperitoneal adenopathy and a slight decrease in hepatic metastases. He underwent genetic testing that could not identify any germline alteration causing MSI high for the tumor, but sequencing confirmed the high number of mutations. BRAF was not mutated within the tumor. We made a decision to change treatment as he continued to feel unwell. What other treatment options are available to him? So the patient has additional standard chemotherapy options, such as FOLFIRI, and also immunotherapy options, such as pembrolizumab, nivolumab, or nivolumab plus ipilimumab available. He was treated with pembrolizumab alone. Imaging showed decrease in his abdominal lymphadenopathy and liver metastasis with this treatment. He regained weight. His energy returned to his pre-diagnosis baseline, and his cough resolved. So how long is appropriate to continue treatment? Without trials to guide us here yet, I treated this patient for 1 year. During the treatment break, after the 1-year treatment, we followed him with surveillance CAT scans. About 6 months later, a CAT scan showed new and increased partially necrotic abdominal and retroperitoneal nodes. What would you do now? Again, we had a few options. We could give chemotherapy as he has standard options available. We could try to reinduce him with immunotherapy. As he did not technically fail immunotherapy, he could be treated with anti-PD-L1 or with anti-CTLA-4 treatment. We decided to restart pembrolizumab, and with this treatment, the lymph nodes again regressed. How long would you treat now? So we have decided to treat for 2 years based on his rapid recurrence while off treatment. There is data from non-small cell lung cancer that responses may be more durable with 2 years rather than 1 year of therapy, though definitive data to guide us here is not yet available. Our third and final case is a patient who presented at the age of 27 years with metastatic rectal cancer involving lymph nodes, liver, lungs, and bones. Her tumor is microsatellite stable. Several parts of her presentation are notable. She presents obviously at a very young age. The incidence of colorectal cancer among people less than 50 years has been increasing since the mid-1990s. Colorectal cancer is now the most commonly diagnosed cancer and the most common cause of cancer death in American men under the age of 50 years. The etiology of this increased incidence in younger patients is not known. All of the increase in incidence has been in distal tumors, particularly rectal or distal colon tumors. This patient had a rectal cancer. She is too young to undergo preventative screening, so when she presented, she had extensive metastatic disease, and treatment is just palliative. The increase in incidence is driven by sporadic cases, often without any family history, and these tumors are primarily microsatellite stable. Molecular testing of a biopsy of the rectal tumor showed that this patient had HER2 amplification, which was read on next-generation sequencing as a 22-fold change. There are multiple ways to test for HER2 amplification in colorectal cancer. Next-generation sequencing can be used, as done in this case. Immunohistochemistry can be used, as well as FISH. Microsatellite stable tumors and left-sided tumors have a higher rate of copy number alterations, and in this case, there is a potential targetable alteration from a copy number change. This patient was started on chemotherapy with FOLFOX and responded to treatment for 6 months. She was then switched to FOLFIRI with bevacizumab and responded to this treatment for 8 months. We then decided to start targeted therapy. What data is there for targeted therapy in this setting? First, she has a left-sided tumor. Recent evidence indicates that right-sided colon cancers do not respond to EGFR targeting antibodies. Second, the presence of HER2 amplification affects chance of response to standard anti-EGFR therapy. Specifically, patients with HER2 amplified colorectal cancer do not benefit from EGFR inhibitors. I say this based on data from preclinical studies, retrospective analyses of patients, and meta-analyses. Ongoing trials will look at this prospectively. Preclinical data and clinical series suggest that HER2 amplified colorectal cancer requires dual HER2 therapy. There are 2 prospective clinical trials showing the activity of this approach. The Heracles trial tested the combination of the anti-HER2 antibody trastuzumab and the HER family TKI lapatinib. This was a phase 2 trial. It enrolled 48 patients. By definition, patients were wild-type for KRAS exon 2 mutations. The response rate for this combination was 30%. The MyPathways trial included an arm with HER2 amplified colorectal cancer that was treated with the 2 anti-HER2 antibodies trastuzumab and pertuzumab. This phase 2 trial enrolled 57 patients. The response rate was 32%. The patient was treated with trastuzumab and lapatinib and responded for 8 months. Are there any biomarkers for predicting response to HER2 therapy? Recent reports of these trials suggest the level of HER2 amplification and the plasma HER2 copy number predicts response. This patient had high level of HER2 amplification in her tissue analysis. We sent blood for circulating free DNA analysis prior to treatment, and this showed a plasma copy number of 23.7, confirming high-level expression of HER2. I hope with these 3 cases I have shown you how biomarkers and targeted therapies can be applied now in the clinic. Thank you.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.